Today's class will discuss about the infections of the cardiovascular system. And so, what are the components of the cardiovascular system? We have the heart and the vessels, right? So, regarding the inflammation or infections of the vessels, we have two types, the veins and the arteries. The veins predominantly we call it as thrombophlebitis. It could be either peripheral veins or the central veins. What are the central veins? Central veins are the veins which are directly connecting to the heart. Now, clinically, what we do see is infections of the central veins are more commonly associated with intravascular catheters. And as far as the peripheral veins are concerned, those are also associated with the peripheral venous catheters. So, we will discuss all those both in the hospital acquired infections and in infections of the catheters, intravascular catheters. Now, coming to the arteries, there is an entity called as arteritis. That means inflammation of the small arteries. Now, these arteritis predominantly are due to inflammatory nature, predominantly because of the various autoimmune diseases, for example, giant cell arteritis. These cases are comparatively less common. However, in today's class, we will discuss about the important and the predominant cases. Okay. So, obviously, the most important part is the heart. Now, as you can see, I think you already are pretty much aware. We can divide the heart into three parts: the pericardium, the endocardium, and the myocardium. And any inflammation may lead to inflammation of either one or both, all of the aspects. Now, let us start. The first is pericarditis. Now, if you see the structure, there is a covering outside the heart that is called the pericardium. The pericardium has both a visceral layer and a parietal layer, and within this peritoneal covering we have something called as the pericardial fluid. Generally, it is about 35 to 50 ml depending on the population that you are concerned with. Now, what is pericarditis? Pericarditis is inflammation of this pericardium. That is inflammation. It may or may not be due to infection. So, clinically, we can divide pericarditis into four types. The first type is the acute pericarditis. Acute means that is very quick in onset, and if the onset is much more delayed, we can call it subacute, and if it is very much delayed, we call it as chronic. Okay. And there is another entity that is called as the recurrent pericarditis. That means after the acute or subacute episode, if the person is again affected, we call it as recurrent pericarditis. Now, what could be the effect of the pericarditis? As I have already said, the pericarditis means it is the inflammation. Now, if there is inflammation, what it will lead to? Inflammation will lead to accumulation of fluid, inflammatory fluid within the pericardial sac. Okay, that is called as pericardial effusion. Now, this effusion, if it goes on and there is a huge collection in the pericardial sac, it will slowly, what will happen? What is the main purpose of the pericardial sac? It smoothens out the movement of the heart. But if the pericardial sac is filled with fluid, much excess than what it normally should be, what will happen? It will hinder the movement of the heart. And as it goes on, sometimes the ventricle may not relax properly. If the ventricle fails to relax, what will happen? The person will end up with cardiac failure. That is the type of manifestation we call it as cardiac tamponade. That means there is a huge collection of fluid within the pericardium which hinders the normal contraction and relaxation of the heart. Another thing that can happen is called as constrictive pericarditis. Now, try to imagine, because of the inflammation, there is fluid within the pericardial sac. And as this inflammation heals, because of the secondary healing, I think you have already learned about healing in pathology, primary healing and secondary healing. Now, what happens with secondary healing? There is formation of granulation tissue, right? So if the inflammation goes prolonged and there is healing and there is granuloma formation, the two layers of the pericardium may stick with each other. Normally it is moving very freely and it has a fluid which can glide one layer of the pericardium over the other. But because of the inflammation, if both the layers of the pericardium sticks with each other, then what will happen? Now the same thing will happen that that the ventricles, it cannot move as freely as possible. That is called as constrictive pericarditis. That means the pericardium is no longer able to move. Okay. And the last is called as effusive constrictive pericarditis. Obviously, as the name suggests, there is both effusion and there are some constrictions. So, all these features may lead to reduced cardiac output. And if the process gets prolonged, the patient may end up with cardiac failure. Okay, till now you have understood? Okay. Now, pericarditis can be, now please remember, pericarditis is an inflammation. Inflammation could be both infectious in origin and it could be inflammatory in origin. That means non-infectious. Now, if we look at the causes, infectious causes, obviously the most common organism which causes pericarditis include the viruses. Among the viruses, we have most commonly the Coxsackie A and B viruses, eco, adenoviruses, parvoviruses, HIV, Epstein-Barr and CMV viruses. These are the common viruses which cause pericarditis. And among them, Coxsackie A and B are very common causes of acute pericarditis. Moving on, if we look at the bacterial causes, perhaps the most common cause is tuberculosis, especially in Indian setting. However, as obvious in the developed countries, the incidence of tuberculous pericarditis is much more less. Other causes would include Coxsackie burnetii, which causes Q fever, Neisseria meningitis, Streptococci, Staphylococcus. Okay. Among the fungus, the common causes would include fungus like Histoplasma, Coccydioides, and Blastomyces. These are all dimorphic fungi. Among the yeast, we have Candida, which can cause pericarditis. And finally, some of the parasites like Echinococcus and Toxoplasma, they may migrate into the cardiac tissue and the pericardium and cause inflammation. So these are the causes of pericarditis. Now please remember, in general, most common etiology of pericarditis is non-infectious. Among the non-infectious causes, remember the most important cause would include malignancies, connective tissue disorders like SLE, rheumatoid arthritis, and metabolic syndromes like metabolic diseases like uremia and myxedema. What is myxedema? Hypothyroidism. Okay. The other causes would include trauma. Any kind of trauma into the mediastinum, maybe trauma, maybe surgery, all these can cause infections, and some of the drugs may lead to pericarditis, inflammation of the pericardium. Okay. Now, what would be the features, clinical features? The first feature would be, see, the pericardium is highly innervated. So, any kind of inflammation in the pericardium will lead to pain in the mediastinum, and that is interpreted by the patient as pain in the chest pain. However, you must be diligent enough to ask about the pattern of the pain, because chest pain is also seen in case of myocardial infarction and also in other gastric entities. Even pain of pancreatitis may be interpreted as chest pain. So, what is most important is that, look at the word, it is called as a non-ischemic chest pain. Now, what do I mean by non-ischemic chest pain? Suppose if there is an ischemia means the blood supply to the myocardium is not enough. Infarction hasn't occurred yet. So, whenever the patient, if he or she climbs, say, one or two stairs, he or she will complain of chest pain. That is called as chest pain on exertion. Whenever the patient is exerting himself or herself, she or she is experiencing pain. That is called as exertional chest pain. However, in pericarditis, we do not see exertional chest pain. The pain is constant and nagging. It doesn't increases with exertion, neither decreases on rest. However, in ischemia, the patient will give a definitive history that the pain occurs on exertion and the pain is relieved on rest. The next important is if there is a huge effusion or there is constriction, that means the cardiac output will be reduced. The ventricles, if the ventricles cannot relax, what will happen? We'll have signs of heart failure. Both may be right and the left heart failure, features of both right heart failure and left heart failure. If there is a right heart failure, that means the venous return will not be enough. We can see dependent edema. In the right heart failure occurs, we can find pulmonary manifestation including cough, respiratory distress, etc. Okay. Now, I have already told you the most common cause of pericarditis is viruses. So, obviously, before the pericarditis happens, in these viral infections, we will find a flu-like viral episode which will occur before the signs and symptoms of pericarditis. So, obviously, you have to ask the patient about the history, whether he or she had an antecedent history about 5 to 10 days before the episode, whether he or she had any flu-like illness or not. Similarly, if the pericarditis is a result of an autoimmune disease or connective tissue disorder, he or she will have other manifestation of the same. And if he or she has a history of trauma or surgery, that can also be elicited. Similarly, you should also take the relevant drugs that the patient may be on or had been treated previously. Now, what kind of investigation that you need to do to confirm that the patient is indeed is having pericarditis? First, you need to do some investigation related to the heart. The common investigation would include get an electrocardiogram done, get an echocardiogram done, whether the movement of the cardiac vessels are normal or is restricted. Now, if there is pericardial effusion, there will be some specific ECG changes. I'm not discussing all those things. In the chest X-ray, if there is a huge effusion, we can find a big cardiac shadow on the chest X-ray. Similarly, because the patient is complaining of the chest pain, we need to rule out ischemic origin. So most commonly, if it is caused due to an ischemia, we will see rising of cardiac markers, that is the ischemic markers like troponins, CKMB. So all these can also rule out ischemic changes. Other than that, we need to investigate for other causes like connective tissue disorders. For that, we need to go do the complete blood panel, metabolic panel. Why? Because uremia, mixed edema, these also can cause pericarditis. Similarly, liver function test, thyroid function test. Sometimes the bacteria may cause, so you should also have to send a blood for culture. In Indian setting, tuberculosis is very important. Many a times the patient may not have signs and symptoms of pulmonary tuberculosis but end up having tuberculosis in other sites of the body. That is called as extrapulmonary tuberculosis. Okay. So you have to scrutinize the patient whether it is of tuberculous origin or not, and sometimes you also need to diagnose the patient whether latent tuberculous infection is there or not. For that, we can go for the CYTB test or the interferon gamma assay. Finally, if there is pericardial effusion, a relevant examination would be to do a pericardial tap, collect the pericardial fluid, and examine the fluid for malignant cells. Okay. So, cytology of the pericardial fluid and its culture can also be relevant. And again, because most of the common causes are viral origin, you can also test for the viral serological markers, thereby helping us diagnosing the condition. Now, regarding the treatment aspect, obviously pericarditis has to be treated. because the predominant pathogenic process is inflammation, non-steroidal anti-inflammatory drugs are given to reduce the inflammation, and sometimes steroids may also be added on. Other than that, we have to treat for specific features. For example, if the patient is having cardiac failure, we have to treat the patient for the heart failure. And if the patient is having say a connective tissue disorder, etc., then we have to treat the same cause. Okay. The next part is myocardium. Myocardium means it is the inflammation of the myocardial cells, which leads to tissue degeneration and necrosis. Similarly to pericarditis, we can divide myocarditis into 4 types. The first type would be an acute type, and the other would be chronic. However, chronic infection may be chronic active or chronic persistent. Now try to understand the difference. Active means the pathology is still going on. But if it goes on for a prolonged period of time, we call it as chronic active. In chronic persistent, the disease process is still going. Manifestation may have reduced, but the disease process is still going. And if the disease process is not being controlled by the human immune system, we call it as the fulminant type of myocarditis, based on how fast the inflammation is occurring. Understood? Okay. Now, if you look at the causes of the agents which cause myocarditis, we have the viruses, and if you look at the viruses, it is almost the same type of viruses which were attributed for pericarditis. But look over here. In case of bacteria, now we have some other bacteria like Legionella, Salmonella, Streptococcus, Clostridium, Mycobacterium, Tuberculosis. Why? Because these bacteria are able to access the systemic circulation. Some of the parasites like Trichinella, Trypanosoma and Toxoplasma, they can also cause myocarditis. That is, from bloodstream it can reach through the cardiac vessels into the myocardium. Now, if we look at the non-infectious causes, the very first common is a type of disease called eosinophilic myocarditis. Other than that, we have autoimmune diseases, drugs which are cardiotoxic, systemic diseases like sarcoidosis or inflammatory bowel disease, and remember, exposure to venoms or chemicals. Now, when we say venoms or chemicals, that means there are many facets. For example, a very common disease is the diphtheria. Okay. Now, what happens with the diphtheria? The clinical case is basically pharyngitis. The organism causes and resides within the pharynx itself, and it liberates the diphtheria toxin. This toxin is absorbed from the mucous membrane into the bloodstream, and the toxin itself causes damage to the myocardium. The bacteria itself doesn't cause any kind of damage to the myocardium, but the toxin does. Similarly, many venoms, maybe scorpion, maybe snake venom, drugs, all these things can cause direct myocardial effect on the myocardium itself. So you also need to inquire about all these things. And finally, we have the autoimmune phenomenon. That means if the body starts to develop antibody against the cardiac myocytes, that means these antibodies or the cell mediated immunity will attack the cardiac myocytes and cause myocarditis. So, if we look at overall, what could be the non-infectious causes? It could be because of the exposure to toxins, venoms, drugs. It could be autoimmune diseases, and it could be because of eosinophilic myocarditis. Okay. Next, now try to understand this thing. Now, when the damage happens to the myocardium, we call it as acute myocarditis. The damage happens in 3 phases. The first phase, we have direct myocardial injury due to whatever may be the agent. It could be an infectious agent, a virus or a bacteria, or it could be a toxin, it could be a drug, or it could be autoimmune. So first what happens is a direct myocardial injury. That means the cells are damaged directly. Thereafter, in the second phase, there is immune-mediated response. The immune system is triggered, and because of triggering of the immune system, we have what we have. There will be liberation of cytokines, activation of the monocytes, tissue macrophages, and agglomeration of the circulating antibodies. So all these things will damage the cells further on. This is the phase 2. And finally, we have phase 3, where either the myocyte can recover from the inflammation or it will degenerate. Okay. Now, if you understand these things, now you can understand why myocarditis has been classified into chronic active, chronic persistent, acute, or fulminant. In case of fulminant, the degeneration is very rapid and progressive. But if the degeneration and resolution is occurring almost at the similar pace, we call it as chronic persistent. Okay? Understood? Okay. Now, how to diagnose? Again, for myocarditis, we need to go for the cardiac investigation. That would include an ECG, echocardiogram, and a chest X-ray. Furthermore, we need to do all the complete blood counts, inflammatory markers including CRP, ESR, interleukins, cardiac markers including troponins, CKMB. Then we need to do some specific cardiac imaging. It may include a cardiac MRI or a PET scan or a FDG PET scan. Sometimes coronary angiography and endomyocardial biopsy may also be required to establish the diagnosis. Now, coming back to the management of myocarditis, obviously, once we find out the etiology, we have to treat it specifically. For example, suppose if it is because of a virus, let's say CMV virus, we need to give ganciclovir or valganciclovir. If it is because of bacteria, we need to give antibiotics. If it is because of tuberculosis, we need to give antitubercular drug. If the patient is manifesting with heart failure, we have to treat the heart failure. If there is a conduction abnormality. Now, keep in mind, in myocardium, the overall damage can also happen to the conducting system. If the cells of the conducting systems are damaged, then there will be conduction failure and erythema may be manifested. So, if there is erythema, which will be evident on ECG, we have to manage the erythemias. If the etiology is an autoimmune, we need to give immunosuppressive therapy. Most commonly, steroids are given. Anticoagulation therapy may be required because of the inflammation. There is a hypercoagulative state within the cardiac environment. For that, anticoagulation therapy has to be given. And furthermore, these two things are very important. Whenever there is a patient who is having myocardial inflammation, the patient must be at rest. The patient should not exert himself or herself. Okay. So try to corroborate when you will be reading about management of a patient infected with diphtheria. You will find out we give all kind of management, and finally the patient is given a bed rest for at least 2 weeks. Because the disease may have been eliminated, the toxin may have been eliminated, but the toxin which has already caused damage to the myocardium needs to rest. That means there should be no exaggeration, so as to the resolution may happen properly. And finally, alcohol limitation, almost because of the same. Okay. So till now we have covered about the pericarditis and the myocarditis. Next we will move on to the endocardium. If there is inflammation of the endocardium, we call it as endocarditis. And it also includes the valves and the valves of the heart. Now, endocarditis can be divided into 4 types. The first type is called as the native valve endocarditis. That means, what is a native valve? The original valve. That means there must be something called as an artificial valve. So, if a patient has a damaged cardiac valve, we can surgically replace that cardiac valve. That is called as the prosthetic valve. Now, inflammation can happen to the original valve also and also to the postoperative valve. Hence, it is divided into either native valve endocarditis or prosthetic valve endocarditis. Other type of endocarditis is based on the patient population that is seen. The first type of population is called as intravenous drug users. The people who inject themselves with various kinds of drugs, recreational drugs are most commonly used. And the next type would be nosocomial endocarditis. And nosocomial means related to the hospital. In some of the patients who are hospitalized because of other diseases or infections, they may end up having endocarditis. Those are called as the nosocomial endocarditis. Now, if we try to understand what endocarditis is a microbial infection and it is involves the endocardial surface of the heart, and it may affect both natural and prosthetic valves also, and there is something called as vegetation that is seen. Now, what a vegetation is? Vegetation is a collection of microorganisms and cellular debris which include platelets, fibrils, and other inflammatory cells, and it is present generally on the cardiac valves. So, this is called as a vegetation. Now, this vegetation, these are commonly seen on the cardiac valves, the chordae tendineae. What are chordae tendineae? The tendons which are attached to the cardiac valves. So, this can affect the chordae tendineum, the endocardium, the endothelium, that is the inner lining of the heart, and the septal cardiac abnormality. Septal cardiac abnormality, it could be a ventricular septal defect or an atrial septal defect. So, wherever there is a turbulence, there is a damage to the endothelium, the vegetation can happen over there. So, most commonly in an intact or a normal heart, the most common area of turbulence is at the cardiac valves, and secondly, it will be the chordae tendineae. And next is the endocardium and the endothelium, which are exposed to high pressure. And if there is any congenital septal defect, it can also be present over there. However, you will see, even with all these aspects, the patients who are actually infected with endocarditis are very less in number. Because for endocarditis to happen, these four character situations must be fulfilled. What are these four? Let us look one by one. First is predisposing host factor. Some people are more prone to get endocarditis other than rest of the population. What are these host factors? People who already have a damaged heart, maybe because of autoimmune disease or a congenital disease, whatever it may be. If there is any abnormality in the heart, the chances are this person may end up with endocarditis in their lifetime. Sorry. Other people would include intravenous drug abusers. Why? Because the drug abusers, they do not care about sterility and any bacteria, generally the commensals of the skin, they end up in the systemic circulation. People with poor dental hygiene. Always remember, our mouth has numerous microorganisms. If the dental hygiene is poor, the transient bacteria can end up in the more virulent organism may end up in the bloodstream. The other would include people with immune suppression like diabetes, people undergoing hemodialysis, etc. The next thing that you must understand is the microorganisms which cause endocarditis. Among them, we can divide the microorganisms into two types. One is called as the culture positive endocarditis and the culture negative endocarditis. We have differentiated it into two types very simply because some organisms can be easily grown on culture and some can't be grown. The organisms which can be grown on culture are called as the culture positive, and those important organisms would include streptococci, staphylococci, enterococci, and Pseudomonas aeruginosa. Okay. Remember the main common coccus: streptococcus, staphylococcus, enterococcus. Okay. Now here comes the catch. Culture negative. Some of the bacteria can cause endocarditis, but they are not grown in culture in the laboratory conditions. Those would include nutritionally variant streptococci. Some type of streptococci, they have a fastidious nutrition requirement. So it is not easily extracted. Other would include Bartonella, Coxsackie boniti causing Q fever, the HACEK group of organisms, HACEK, HACEK group of organisms, they cause endocarditis and they are very difficult to retrieve in the culture. Other would include chlamydia, Legionella, Brucella, and some funguses like Candida and Aspergillus. These can cause culture negative endocarditis. The next comes is called as transient bacteremia. What is transient bacteremia? See, whenever we are doing any activity with our mouth, it could be brushing your tooth early in the morning, on the evening, or simple habits like chewing. What it does, it dislodges the microorganisms from the gums or in the dental crevices, and small trauma happens. These organisms may enter into the bloodstream and cause endocarditis. This is called as transient bacteremia. But keep in mind, this doesn't happen routinely. Otherwise, almost everyone would have ended up with endocarditis. Does that happen? No. So why some particular type of organisms can cause endocarditis? Because if you had seen, most of the organisms which were causing endocarditis belong to gram-positive cocci, other than the organisms which are not culturable. So what actually happens is, within our bloodstream, there is a particular system called as complement system. I think you are pretty much aware with that. Now, if you look at the pathway of the complement system, the end goal is formation of what is called as a membrane attack complex. And this complex attaches itself to the bacterial cell wall and forms a huge pore in the cell wall. Thus, the bacteria gets killed. Now, this membrane attack complex is more efficient in killing gram-negative bacteria as compared to the gram-positive bacteria. Predominant reason is the gram-positive bacteria will have a higher cell wall thickness. This is the reason why you see most of the microorganisms, that is the gram-positive organisms which are present in the mouth, they end up causing endocarditis. That is why you will find whenever any dental surgeon is going for any kind of procedure, whether the patient has an infection or not, he or she will prescribe antibiotics. Because whenever a dental procedure is being done, huge number of bacteria enters into the bloodstream. Next is the immune system. The role of the immune system, as I have already told you, also determines. Because in the bloodstream, bacteria is generally killed by the complement systems. And I have already told you the gram-positive organisms may escape the complement system. Now, what would be the clinical manifestations? The first thing is obviously fever. The fever may be present both in pericarditis, myocarditis, but in case of infective endocarditis, the fever will be very high grade. That is why I have written over here, it is more than 38 degrees centigrade. Very high fever. Next, we can find murmurs, cardiac murmurs. Why we can find cardiac murmurs? The valves may be involved. If the valves are involved, the cardiac sound will be abnormal. That is called as the murmurs. It could be because of the vegetation itself, or it could be because of the inflammation itself. Next, we can find splenomegaly. Whenever there is a systemic infection, the activity of the spleen increases, trying to get rid of microorganisms and cells infected with bacteria. So we can find splenomegaly, new or a changing back pain. This microorganism, the vegetation may dislodge to any part in the body and thereby causing various manifestations like, look over here. These are called as splinter hemorrhages. Splinter. Splinter means, suppose you are working with your bare hand, sometimes splinters of wood may enter into your nails. Has it happened? Like a small piece of thorn or a wood has entered into the nail bed. Just look over here, the hemorrhages looks like small pieces of wood had entered into the nail bed. This is called as splinter hemorrhages. A similar kind of hemorrhage may be seen in the retina. We call it as the Roth spot, and along with that I think you can see an hemorrhage over here, that is called as the next type we can see is called as conjunctival petechiae. Petechiae are also hemorrhages. You can see very small dots of hemorrhage in the lower palpebral conjunctiva. Or we can find manifestations like osteolar nodes generally present in the joints of the hands. Or skin lesions, these are called as the Janeway lesions. These lesions are very much indicative of infective endocarditis. Next, we can find any kind of embolic manifestation, maybe systemic, maybe pulmonary. If the embolic manifestations happen in the pulmonary circulation, we can find the patient complaining of cough, dyspnea, and chest pain. And if it goes into the systemic circulation, you can find embolic event may happen in limbs, or if it happens in the cerebral circulation, we can find the patient complaining of stroke syndrome. Okay. So for diagnosis, what are the investigation we must do? Say the infection is going in the endocardium. So the vegetation is directly in contact with the blood. So it is very prudent to get a blood culture so that we can obtain the organisms. But here's the catch. Organisms are generally present within the vegetation itself. So there is no continuous seeding of organism into the blood. It will be intermittent. Hence, we need to take multiple samples of blood for culture. So what should be the ideal number of blood culture? It should be at least 3 sets of blood culture. Set means one aerobic, one anaerobic bottle. That is 2 bottles constitute 1 set. So we must take 3 sets of blood culture. Understood? That is the number. Next is when. These should be drawn at least 1 hour apart, and all should be taken within 24 hours. Have you understood? So we need to take 3 samples within 24 hours, and every sample should have a difference of timing at least 1 hour for between each set, and 2 culture bottles for 1 set. Okay. Next, other investigation would include a complete blood panel, a metabolic panel, inflammatory panel including ESR, serum BNP, serum antibodies for some infectious agents like Bartonella, Coxiella, Chlamydia, because they cannot be grown in the culture. So the diagnosis remains with the serology. Next, we can also go for some serological investigation like beta-D-glucan or galactomannan for the fungal etiology, be it a candida or aspergillus. Other than that, we can get the routine investigation like ECG, echocardiography, or a chest X-ray and CT scan. So these are the investigations. However, for diagnosis of infective endocarditis, we have to use what is called as the Duke's criteria. What does the Duke's criteria state? We have a major criteria and a minor criteria. I'll go through the major criteria. What is the major criteria include? Typical organism found in 2 separate blood cultures. That typical means organisms which are associated with infective endocarditis. If that doesn't happen, or persistently blood cultures, or organisms like Coxiella which are not grown in culture but the serum antibodies are very high, or a new valvular regurgitation, that means a valvular damage which was not present earlier, or we have an echocardiogram which is abnormal and is indicative of presence of a vegetation. If these are present, we call it as the major criteria. Now for diagnosis, if we have to define endocarditis, at least 2 major criteria may be present, or 1 major, 3 minor, or 5 minor criteria. That will constitute a definitive endocarditis. And if that is not possible, we call it as possible endocarditis, which would include 1 major and 1 minor criteria or 3 minor criteria. So I'll just go through the minor criteria. That is, there is a predisposing cardiac condition, or the patient is an injection drug abuser, or fever more than 38 with vascular phenomenon. I have shown you the pictures of the vascular phenomenon. If those are present, The positive blood culture report comes positive, however, it does not define the major criteria. And if immunological phenomena like ocellar node, Janway's lesions, Roth spot, these are present, these constitute the minor criteria. Now, coming to treatment of infective endocarditis, obviously the treatment involves use of antibiotics to get rid of the organisms. Next, we have to assess whether the patient is undergoing any gradual damage to the valves or not. If the valves get damaged, then obviously valve replacement has to be done, and if the patient end up with a cardiac failure, treatment of the cardiac failure has to be done. Okay. The last part of the today's lecture will cover something called as acute rheumatic fever. Now, what is acute rheumatic fever? Rheuma means humor. Fever is a manifestation after an episode of fever which affects not only heart but also other parts of the body. So, what happens actually is a person, generally a child, gets infected with or has a disease that is pharyngitis caused by a particular organism, that is the streptococci. And even in streptococci, the particularly group A streptococci. After the infection, the body tries to recover from the infection and get rid of the bacteria. These bacteria are then cured. They will be degraded, right? And the antigens will be processed. Now, during the degradation and presentation of the antigens, the streptococcal antigens are processed and antibodies are produced against it. However, these streptococcal antigens have some similarities with the human structural entity. And after the infection gets over, the antibodies are produced and they attack the human cells itself. This is the process of acute rheumatic fever. So, acute rheumatic fever is an autoimmune condition and it is caused after group A streptococcal infection. It could be a pharyngitis, it could be a skin infection. What it leads to? It leads to non-suppurative. Non-suppurative means without formation of pus. Inflammatory lesions, that is, inflammation is present without formation of pus. That means macrophages and monocytes are not present over there. Where are the lesions present? These are present over the heart valves, brain, joints, skin. These are the areas that are affected. And if this inflammation goes on for a prolonged period of time, we call it as rheumatic heart disease. So most of the cardiac abnormalities that were seen, not now, say about 20 to 30 years ago, especially in adults, was all resultant due to rheumatic heart disease. So for an adult not to develop a rheumatic heart disease, it is very important that during the childhood, we must be able to treat each and every episode of acute streptococcal pharyngitis. So many people were attributed for this, attributed for understanding of the disease pathogenesis, including Sindehem, etc. And you will all come across these names. Now look over here, what happens? Suppose there is a susceptible host, a child, and this host gets infected with a streptococcal infection, be it a pharyngitis or a skin infection. And from where the child will get the infection? From the environment, that is, another person who is having the infection. So, overcrowding, lack of hygiene, or uninhabitatory conditions where people live in, especially in poverty, overcrowding, etc., these all predispose the children living over there to the streptococcal infections. So, what happens is the first event is a precipitating infection of group A streptococci. During the first episode of the ARF, what will be the manifestation? The child will manifest with fever and signs of pharyngitis, nothing else. After that, the organism is broken down and the antigens are presented which produce antibodies. And there is something called as molecular mimicry. Mimicry means similar. That means the bacterial antigens mimic that of the human antigens. And they will trigger a T cell response. T cell response will lead to cell damage. How? Based on targeting by the antibodies against those specific antigens. And suppose this event has occurred. The same child gets infected with streptococci again, say about 1 to 2 years later. Now what will happen? These antigen will be exposed again, more antibodies will be produced, and these antibodies will trigger more T cell response into the other local tissues. So more tissue damage will happen. And if this cycle goes on and on and on, after a particular amount of time, you will find a child or a young adult with various clinical manifestations. So what are the areas that are affected? The first part is affected is obviously the heart. It can affect the valves, aortic or the mitral valves. It can affect the joints, brain itself, and skin tissues. For example, if it attacks the junctions, neural junctions, it will lead to disorganization of the or inability of the brain to function properly, especially the motor function. And it may lead to abnormal gait movement. As you can see, this child, when she is trying to walk, she has an abnormal movement. This abnormal movement is called as chorea. And the chorea that is seen in the background of acute rheumatic fever is called as Sindh-Neham's chorea, named after the person who had described this kind of abnormal movement. Next part I have already told you, the heart is affected. Now, what are the regions of the heart it may affect? It may affect the cardiac valves, it may affect the endothelium, it may affect the myocardium. Particular bodies like Ashcroft bodies or inflammatory bodies may be found in the myocardium, and cardiac valves may be affected, which may lead to mitral or tricuspid valve, both stenosis and regurgitation. Do you have any idea of stenosis or regurgitation? No. Stenosis means? So, what is the normal function of the cardiac valve? It must open and close, right? Now, whatever the movement happens because of the chordae tendineae. If the chordae tendineae does not become pliable, that means it does not allow any movement. What will happen to the valve? The valve will remain semi-closed or closed position. So the opening of the valve will become stenosed, that is narrowed down. Now suppose if the chordae tendineae becomes very lax, so what will happen? Every time the heart contracts and relaxes, the valve will just open and close without giving any kind of resistance. That is called as regurgitation. And this stenosis or regurgitation may eventually end up with cardiac myopathy or other manifestations based on that. So, if you can see in this cardiac, we can find a very enlarged heart. This is because of the regurgitation, where I think in physiology you have learned about the various factors which may lead to hypertrophy of the heart. No. Okay. And you can see in cut sections, the chordae tendineae are affected, hence leading to valve regurgitation. Or the next thing is, it can affect the conducting cells of the heart, thereby leading to what is called as heart block. It could be a first degree or second degree or a complete heart block, and other changes in the ECG. Regarding the joints, what happens is all these antibodies that are produced, they will go and attack the synovial cavity. And the antigen antibody complexes will be deposited and they will be attacked by various factors, including the complement, leading to inflammation of the synovial area. Patient will complain of severe pain. Another characteristic that is called as arthalgia. Okay, and if this process goes on for a prolonged period of time, we call it as arthritis. Arthalgia means inflammation, and if the inflammation causes damage to the joint cell surfaces, we call it as arthritis. Okay. Another interesting phenomenon that happens is called as migratory arthalgia. Migratory means the patient will say, "Sir, 2 weeks earlier I had severe pain in my right knee, and now I am having pain in the left knee. But the right knee is now painless." Actually, what happens is, when the antibodies are produced constantly, a huge amount of antibodies will be deposited on a particular joint. As most of the antibodies are consumed by that joint, now the number of antibodies in the body has gone down. After 2 to 3 weeks, when the antibodies titer rises again, now right antigens of the right knee will not be affected. Now the other joints, these antibodies will attack other joints, and that joint will become more painful. So the patient will complain of migratory arthritis. As you can see, it generally affects the large joints like the hip joint or the knee joint, but it may also affect ankle joints and the wrist joint. Similarly, inflammatory changes may also happen on the skin and subcutaneous tissue. If it happens on the subcutaneous tissues, you can find some nodule-like structures that can be appreciated. These are called as the subcutaneous nodules. Or direct skin manifestation, like you can see red color margins. It is called as erythema marginatum. Erythema means red color, obviously marginatum means along the margins. You can see circular shaped margins of red color. Like the Duke's criteria, we have a Jones criteria, modified Jones criteria for diagnosis of acute rheumatic fever. What it involves? Remember, carditis, chorea, arthalgia, and subcutaneous nodules and erythema marginatum. If these are present, we call it as Jones criteria. মনে থাকবে কি কি হলে কোথায় কোথায় এফেক্ট করে, কোথায় কোথায় এফেক্ট করে, কি কি ছবি দেখালো? Carditis, chorea, arthalgia or arthritis, subcutaneous nodules, and erythema marginatum. If these are fulfilled, we call it as fulfillment of the Jones criteria. And there is a minor criteria also for diagnostic criteria. We have either two major criteria or one major or one minor criteria. If that happens, we call it as ARF. Minor criteria includes polyarthalgia, hyperpyrexia, ESR, and prolonged PR interval. Treatment: every episodes of acute rheumatic fever must be treated with antibiotics. Okay, and if this manifestation has already been developed, we need to give prophylaxis with antibiotics till the child at least 20 years or the child becomes an adult. Otherwise, the child will end up with rheumatic heart disease. So overall, we can summarize this episode into this picture. For diagnosis, we can find the Jones criteria. This is the reason the antibodies and the T cells both are affecting the various tissues of the organ, and the whole pathology goes on over here. Okay, now can you understand this picture? Causative organism is group A streptococci. After the infection, either in the throat or in the skin, the infection happens. The antigens are released, the antigens will produce antibodies. These antibodies will attach to the various cell surfaces of the body, and the T cells will further attack the antigen antibody complexes. These cells would include the cardiac cells, the joint cells, and skin, and the neural junctions. Thereby manifestation, 5 main type of manifestations: carditis, chorea, arthritis, subcutaneous nodules, and erythema marginatum. Diagnosis is done by Jones's criteria. Treatment should be antibiotics, and if it is a recurrent case of rheumatic fever, the patient must be given antibiotic for a prolonged period of time. Okay, I have just given you a very brief of the management of acute rheumatic fever.